Today we're going to be talking about quality measures. I mean, quality measures are a core component to value-based care and what we do here at Arcadia. We have an entire module built out and an entire measures engine built out that we're going to get into, talk about a bunch more. They are, generally used to measure the performance of contracts and how providers specifically across organizations' networks are performing within those contracts. So let's jump to the first slide here. And basically what this is Arcadia's measures engine. So in Arcadia's measures engine, we rely heavily on data from across your network. That includes claims data, which comes in usually about monthly, clinical data, which we at Arcadia ingest up to daily from any of your EHR sources. And then also we get supplemental lab data, and that can come in daily. It can come in with your claims data as well. All of that data then gets ingested into what we call our measures engine, and that measures engine outputs the results of the measures. These measures can be HIMSS. We are NCQA HIMSS certified. We go through that process every year. Very important piece of our business. And then we also have measures from multiple different stewards as well as HIMSS. So CMS measures, PQA measures, anything you can really need, we probably have a measure for it. And, these measure outputs can be done as frequently as daily. And, that's a big change in the industry compared to the provider or payer quality reports that, get disseminated monthly. And then you're relying on, at that point, pretty stale data. It's not up to date. It's only available with what the payers have, versus the Arcadia measures engine integrates that clinical data, and it provides so much more of a real-time view of what your organization's measure performance looks like. So that's the general high-level overview of how the measures engine works and sort of the timing around it. So I'm going to go ahead and jump forward a little bit. And then, there's multiple reasons the measures are important in what we do and why you'd be using Arcadia. First and foremost, they are a great view into how you're performing in a lot of your contracts. Specifically, if you have a STARS program, you're trying to hit that 5-star mark. And one of the best ways to do that within our quality engine is the use of supplemental clinical data. If you're just relying on payer data and the data that we're getting from those payers, it's going to be missing a lot of those point of care results, a lot of that lab data. It's not as timely even when we do get it. So when you're trying to make, you'll see insights here in the next spot. When you're trying to make updates to your network and performance improvements plans, that data being lagged, it's a problem. So bringing in this supplemental data, gives you a much better chance at knowing where your problems are early, finding them, identifying them, and solving them, so you can hit that 4 or 5-star mark that your organization really wants to hit. And as you can see, actionable insights, they kind of go hand in hand. You want to use this measures data to make, updates through your network. You can reach out to specific providers. You can find holes in sort of your point of care and use these measure results to, improve upon that info.
Yeah, and I mean, one of the key ways in which you can improve upon that kind of feedback. One of the ways that you can improve upon that sort of feedback is through proactive and meaningful outreach. If we think about payer reports that are coming in monthly, sometimes quarterly, lagged data, you send that out to a provider and they look at this and say, well, I know that in the past month or in the past quarter, I've closed 20% of these gaps. So for them, they have to go through a process of reconciling who truly is still a gap before they can begin doing that outreach. Having that clinical data makes it more real time, knowing within the week, within the month, how many gaps have been closed that might not have gotten back to the payer quite yet, allows for them to actually know that the gap list that's been sent to them is truly the gaps that they have open today. And then through Arcadia's outreach capabilities, there's an integrated way to then send out text messages or get in contact with those patients, with those members, and say, hey, we recognize that, you haven't come in for colorectal cancer screening. Reach out to us. We can help set up an appointment with you, et cetera. But it allows for that more real-time, interactive way of interacting with your patient population and with your members. The other thing, too, is building trust and showing accuracy with your providers. One of the biggest challenges that we see in the industry today is providers that don't trust the data that's presented to them, and being able to show them that what they're doing every day in their EHR is integrating back into the reports that they receive helps build that trust. If they see that, Jane Doe came in last week, had a mammogram done, but then the report from the payer in a month says they still haven't had their breast cancer screening, that's a frustration for that provider because it takes that much more effort, which we all know their time is limited. Spending time on tasks that are not actually improving care in the moment is a challenge that they face every day. So being able to help support that through this more real-time data is something that's critical to overall performance as well as their satisfaction. So what we wanted to do here is kind of outline a couple sample use cases of how organizations use our measure engine, especially as we think about the clinical data and the lab data that's integrated. One of the big things that is done, across a couple organizations that I specifically work with is campaigns around med adherence. So although this is not specifically leveraging clinical data as much as looking at pharmacy claims that are coming in and understanding who is filling medications and maintaining the right level of adherence across the medications that they need on a daily, monthly, weekly basis, is the ability to do that outreach, have more real-time reports, understand where you might have risks in patients that are going to fall below the compliance level that's required, and again, through some of the additional Arcadia capabilities, conduct that outreach and be able to get in contact with people sooner in order to keep them on the side of compliance, especially as we think about things like med adherence and PDC scores for patients. As we get later into the year, it's much easier for someone to fall out of compliance, and being able to stay ahead of that with them is critical, especially as we think about the last couple months of the year. Supplemental data submission. So to Zach's point earlier, if you think about the ability to perform at a high level with your payer contracts, if you think about stars rating, being able to stay at 4 or 5 star performance for a lot of measures requires that you have some of those supplemental data points that payers don't always get on their own. Through that clinical data integration, we can see that more real-time performance within the application. But for many of our customers today, we also can support the submission of that supplemental data back to the payer so that they're also able to recognize that performance level when we think about incentive payments and other performance, that they're being tracked on every year. This also gives them a better positioning with the payer in order to contract their plans for future years as well. Two last things that we wanted to touch on. So clinical data-driven quality incentive programs. Some organizations that we work with today have incentive programs for their providers that don't even look at payer data. It's really just solely focused on clinical data. And as we think about organizations that have networks with multiple EHRs and disparate data sources, being able to bring that into one specific location allows for that organization to spend more time on helping their providers perform at a higher level, have more real-time understanding of their performance, and also integrate that with, in some cases, let's say you have patient population that is value-based care managed by payers, and then those that are not, having a real more focus on population health, not just those patients that are a part of a contract that you might be responsible for today. The last thing, I think a lot of what we've talked about today is kind of taking that provider lens on Arcadia and the measure engine and performance, but there's also value here if you're a payer thinking about Arcadia or how you can better support your provider network. Again, as we think about performance and the reports that they send out today, they could be lagged by a couple months, which is really not so helpful to the provider when they open that report and look at how they can take something actionable out of what's shared with them. By having that clinical data available to them, it allows for them to also be able to provide more real-time reporting, more up-to-date views on how they're truly doing, not just based on the claims data that they have. And it helps build trust. As we think about the transition to value-based care, it's really kind of held back by a provider's ability to feel comfortable with what they're going to be managed against in those contracts. And if you can build that confidence that, you're really doing better than you think, and moving to value-based care isn't going to be as painful as you expect that it could be, that will also help the uptake of value-based care in general. So, Zach, any other?
Yeah, so that's pretty much our talk for right now. Does anyone have any questions? Yeah.
One of the things that we really focus in on is, how a provider organization or a payer organization is performing today. Where are the gaps that they're identifying? Where do they feel like there's data missing or that could help them better perform in their contract? You can get very much so in the weeds everywhere. And at the end of the day, that'll really stall out the ability to adapt and kind of adopt a platform over time or a new capability. So, if you can identify 2 or 3 specific areas where there's a challenge with performance or where there's pain within the organization, get those squared away first and then move on to other areas. It'll help speed up that adoption. And if you can build trust early on in a couple key areas, that'll also help providers and others feel comfortable with what they're using. If you throw everything at them at once, it's going to be a bit more of a challenge because they're going to get confused, feel overwhelmed, and they might not adopt it at all. So it's really about identifying those kind of key initiatives or areas of pain today and then working there to start. It depends on the organization. I would say in general, we'll bring in the claims data that they have from their health plans, clinical data from their EHR, if they have local HIEs, where they have the ability to pull in data points from outside of their specific system. We'll bring in HIE data, lab data from organizations like Quest. We'll also bring in supplemental risk data from CMS as an example, ADT messages for discharges, admits, transfers, things of that sort. So it'll vary from organization to organization, but anything in that realm is reasonable.